I want to talk to you in this video about the non-narcotic analgesics. We're going to focus on the salicylates, acetaminophen, and a large group of medications which are generally referred to as the non-steroidal anti-inflammatory drugs, or the NSAIDs. So these are drugs that can be used for analgesia, which of course is decreasing the perception of pain, but they're non-narcotic, so they are going to act primarily outside of the central nervous system. So we're going to run through the therapeutic actions, the common side effects and toxicities, and some factors that distinguish between the groups. The salicylates, the aniline derivatives, acetaminophen being probably the most common, and the non-steroidal anti-inflammatory drugs, or the NSAIDs, ibuprofen being an example, although there's lots and lots of non-steroidal anti-inflammatory drugs. So when we think about non-narcotic analgesics, we are thinking about using medications for the treatment of pain, but minor to moderate pain, traditionally, is what we think about. So like kind of run-of-the-mill pain, headaches, arthritis, those kinds of things. Oftentimes these are used habitually, and so that's something to take into consideration. So for the salicylates, aspirin is a great example, although there's other sorts of examples as well. The anilines, acetaminophen, like I mentioned, Tylenol is probably one that's very common and that you probably are more than familiar with. Phenacetin is another one that if you're from Europe, you have heard of probably. And then ibuprofen is our primary non-steroidal anti-inflammatory, although there's lots and lots and lots of those. So I kind of want to first look at therapeutic effects of the salicylates versus the anilines, and again, acetaminophen being the most classic example of an aniline derivative. So on the left side of this slide, we have the therapeutic effects of the salicylates. On the right side of the slide, we have the therapeutic effects of the anilines. So they're all going to be, they're analgesics, so they're all going to relieve pain, right? That's kind of a given. The big difference, there's a couple of differences. First big difference is the salicylates have an anti-inflammatory effect, and they also have an anticoagulant effect, where the anilines do not. And so you can see that there. The salicylates have sorry about all that noise, my dog is having an itch. The salicylates have an anti-inflammatory effect and an anticoagulant effect. And so they are going to be, when we're thinking about pain, we're going to think about if the pain has to do with an inflammatory condition, like an arthritis, specifically rheumatoid arthritis, then the better choice in this case would be salicylate. If the pain had nothing to do with inflammation, then either choice would be effective, right? So if they have a headache, cramping, that kind of thing. Both of them are going to lower fever. You can see that in the second bullet. That's antipyretic. That's what that means. They decrease the body temperature. And then again, the salicylates, they have an anticoagulant effect. So as I'm sure many of you know, oftentimes people are prescribed a baby aspirin, 85 milligrams, which is a very small dose, to prevent coagulation. So if somebody is at a risk for clots or strokes, oftentimes they are put on a baby aspirin, one baby aspirin a day, to minimize their likelihood of actually developing a clot. So you can see that there. The acetaminophen does not have that. So there's no reason to take acetaminophen if you're trying to not develop a clot, and there's no real pronounced anti-inflammatory effect with acetaminophen. But if it's just a headache, if it's menstrual cramps, sprains, muscle pain, etc., either one of these would be appropriate. When it comes to side effects and toxicities, again on the left side, we have salicylates. On the right side we have the anilines, and we're going to see another slide in a minute. So one thing to know, it's important to remember about drugs like aspirin, salicylates, is they are known to be GI irritants. They irritate the gastrointestinal system, and they can cause bleeding. And because they're also anticoagulant, if they do cause bleeding, you're less likely to clot. So gastrointestinal bleeding is not uncommon with aspirin, especially if you have to kind of think about why someone would be taking this. So if they're taking it for pain, like an inflammatory pain like arthritis, they're going to be taking it all the time, likely. if they're taking an aspirin because they are trying to minimize their risk of stroking, they're going to be taking these habitually. So for those patients, you want to have that on your radar, that they can potentially develop a GI bleed. GI bleeds are a little bit hard to find. How you'll see this is like an unexplained anemia in a person that you wouldn't expect to be anemic, like a postmenopausal woman, for example, or an elderly male, or a male in general. So kind of keeping your eyes on that situation. Anemia is something that gets commonly missed. And in this case, the anemia would be due to a chronic bleed. Once the aspirin is removed, you can see that the gastric mucosa will heal quickly, right? This is epithelial tissue. It heals brilliantly. And so once the insult is removed, usually the mucosa will heal in 3 days and they're back on track. One thing to caution patients on aspirin habitually is to watch for signs of bleeding. And one classic sign of a GI bleed is black stools, right? The blood gets digested and it oxidizes and it turns black. Another thing that's not super common but possible with salicylates and not likely with anilines is they can cause respiratory stimulation. And if that's the case, the CNS stimulation can stimulate, the respiratory system, so they start to hyperventilate essentially. And when they hyperventilate, they blow off more carbon dioxide, and it can cause them to become alkaline. So again, not super likely, but a possibility. And neither one of those, the GI irritation nor the CNS stimulation, is characteristic of acetaminophen. However, with acetaminophen, when we get into like the toxicities with chronic use, there's a couple of things that you'll see with acetaminophen and not with salicylates. So with salicylates, toxicities with chronic use, with chronic aspirin toxicity, there is a syndrome that looks a bit like what happens when people are being treated for malaria, and it's called synchonism. And how that looks is it's ringing in the ears, potential hearing loss, which is usually reversible on the discontinuation of the aspirin. And sometimes they can become dizzy because the aspirin inhibits an enzyme in the cochlea, which is the center for balance in our inner ear. You might see a slight decrease in glomerular filtration, which is not as significant as you could see with acetaminophen. We don't generally see any blood disease other than the potential bleeding that we talked about. So you don't see like a suppression of the blood production, and there's no link to bladder cancer. However, with acetaminophen, there is a link to bladder cancer. There is some blood dyscrasias that can happen, so some suppression of blood cell production. There very definitely is potential kidney damage, and the most significant thing to remember with a toxicity with chronic use or even just one overdose of acetaminophen is irreversible liver damage. And actually, this is one of the most common causes of death in the ER is acetaminophen overdose. So there's a reason why the acetaminophen is dosed the way it's supposed to, and there's a reason why it says like do not ingest more than 8 tablets or capsules per day, and it's because this acetaminophen overdose can cause irreversible liver damage that can and often is fatal. There's no hearing loss. That doesn't seem to be as big of a deal. So those are the toxicities to be aware of with these two medications. I said the link to bladder cancer, but I forgot to put the bullet up there. So those are the differences between salicylates and anilines in the toxicity department. There is an antidote for acetaminophen overdosage, and the key to it is it has to be administered promptly within, ideally, 10 hours. Even better, it would be even a shorter window within the acetaminophen overdose, and that is acetylcysteine, which is called Mucomyst, is the brand name. And that can protect the liver from damage and death in many patients. So if somebody does ingest a toxic dose of acetaminophen, then the Mucomyst is a good antidote to that. Another thing to note is this condition called REYE'S syndrome, and this has to do with salicylates. And or pardon me, acetaminophen, and this is rare, and but it is an acute life-threatening condition, and it's been associated loosely. This has not been like completely, what's the word I'm looking for? Confirmed. But there's this association between a viral infection and the treatment with acetaminophen. And so the condition is called REYE'S syndrome, and what it does is it causes severe liver injury, vomiting, and lethargy. It causes a lot of central nervous system interruption, and it can lead to belligerence that can continue to progress to delirium and or coma. The mortality rate of REYE'S syndrome is 20 to 30%, and if they do survive it, oftentimes permanent brain damage is a result. So again, it's a causal relationship between salicylates and REYE'S syndrome, but for that reason, the general rule of thumb is to not give kids aspirin when they have a fever. Kids, including teenagers. So if they have the flu or the chicken pox or the measles or any kind of childhood illness, then we're going to try to steer clear of giving them aspirin to bring the fever down, and instead we would give them something else like acetaminophen. I think I might have said in the beginning that REYE'S syndrome was associated with acetaminophen, and I didn't mean to say that. The REYE'S syndrome is associated with salicylates and children. And again, it's a causal relationship. It's a very loose relationship. There hasn't been a direct like cause and effect kind of correlation drawn, but it's this potential relationship. And so for that reason, just to be safe, the caution is to stay away from aspirin in your general childhood illnesses that have that are accompanied by fever. This is a brain of a person with REYE'S syndrome, so it causes in this case, of course, this would have been a fatal situation, but it causes a lot of brain swelling, hydrocephaly, and that's what you're seeing there. So I want to mention the non-steroidal anti-inflammatories for a minute, of which there's a lot, and you can see here on the list, some of them you might be familiar with. Ibuprofen, you can see naproxen, these kinds of things. The COX-2 inhibitors are kind of a newer version of these drugs, and they were designed to be a little bit more effective than your standard non-steroidal anti-inflammatories. So basically, when we are talking about these non-narcotic analgesics, what we saw with aspirin is it works really well, right? The salicylates work really well, but there is that association with the GI bleed. And so these drugs were designed to work like aspirin, but not cause the GI bleeding. And so, because there's so many people with these inflammatory conditions that require pain medication, and aspirin's just really not that effective. I mean, it's effective, but it's not that reasonable of a treatment because of this GI issue. So these non-steroidal anti-inflammatories were designed. Turned out that yes, they are similar to aspirin, meaning in efficacy. Yes, they're gentler on the stomach, but it turned out they were more toxic to the liver, to the kidneys, and to bone marrow. So what they basically did is they inhibit another place on the pain pathway, on the prostaglandin pathway. So I'm going to show you a picture of this. And I just want to preface this by telling you you're not responsible for memorizing all this. I just kind of wanted to bring it up. So prostaglandins, of course, as you remember from physiology probably, or maybe not, but prostaglandins are a group of fatty acid derivatives, and they affect biological processes near their point of release, and then they're pretty much deactivated at or near the point of release as well. So they are direct acting. Right? They're not long-term agents, they're direct acting. And they oftentimes will function as essential intermediates between a given stimulus, in this case, something that causes the pain, stimulates the this kicks off this pain pathway and its cellular response. So essentially they're effective at, cutting off that pain response somewhere in the pathway, usually kind of a downstream. So in this same vein, there are enzymes involved in prostaglandin production. So an enzyme called cyclooxygenase, or abbreviated as COX, and there's different forms of it. This COX enzyme is involved in the production of prostaglandins. And again, remember, prostaglandins are like signaling molecules that are direct acting. They act at their point. They're released at a point and they act at that same point. So the COX enzyme, cyclooxygenase enzyme, has two isoenzymes. One is the COX-1, and it's found in all tissues, and one is COX-2, and it's inducible by inflammatory stimuli, but it's notably absent from GI tissues. So remember, these drugs are often used in inflammatory conditions, and we're trying to not mess up the GI tract. So that COX-2 enzyme was a very important enzyme in this whole development process, because we feel that the COX-2 inhibitors, so if we were to be able to inhibit that COX-2 enzyme, which is again inducible by inflammatory stimuli but absent in GI tissues, if you could inhibit that COX-2 enzyme, that would permit the relief of the pain, so it would cut the pain pathway, and also the inflammatory effects. So it would be analgesic and anti-inflammatory, but minimize the GI side effects, right? Awesome. Yes, very good. Also, they do not have antiplatelet effects, so they don't do anything with coagulation. So all of that sounds great if you have, someone who's wanting to manage their pain because they have arthritis, right? So all of these are good. All right, so here's kind of a little flow chart. Again, remember, you don't need to memorize this. I just kind of want to get you in the right, thinking. So here's how prostaglandins are formed. So up there from the top, essential fatty acid, linoleic acid. This basically works on cell membrane phospholipids, right, which then can get further converted into arachidonic acid. Arachidonic acid we think is a pro-inflammatory acid. So you can see the aspirin and the COX enzymes will inhibit the production of the PGG2 and the PGH2, which cause pain and vasoconstriction. And then from there you can see, some of these other things that happen as a result of this, but you don't need to remember all of these prostaglandins. But by aspirin, but basically what aspirin does is it blocks this. So it blocks the vasoconstriction, it blocks platelet aggregation, right? And it also blocks pain, which is some of these guys are down here, right? So that's all kind of helpful if you're not wanting them to clot and if they're having pain. What else do we want to say? I guess that's good enough about that. So the COX-2, so aspirin, these are your salicylates. So we've already talked about these. These are the COX-2 inhibitors. That's a type of non-steroidal anti-inflammatory. So here's another, this one's a little bit cleaner. So here's kind of an example of a pain, kicking off a pain pathway. So in this case, we've driven this sharp object into someone's tissue, which of course is going to cause all sorts of issue, right? That's tissue injury. It's going to cause inflammation. Histamine is going to be released. It's going to get hot. Pyrogens are going to be released, which are going to cause more blood, cause more vasodilation, etc. It's going to kick off this whole pain pathway. So pain mediators are going to be released. They're going to stimulate pain receptors, which is going to set this whole thing, send this message to the brain to tell you that, ouch, this hurts. We've just put a nail into our skin. All right, so the COX-2 inhibitors, so aspirin would block right here, right? Aspirin blocks the conversion of arachidonic acid into these different prostaglandins. And it blocks right here. So it blocks platelet aggregation, it blocks pain and inflammation. We've already talked about that. And this way here also damages the stomach. The COX-2s don't do this, but they do this, right? So these are called selective COX-2 inhibitors. The non-selective COX-2 inhibitors are downstream here. So these selective COX-2 inhibitors, they deal with the pain and inflammation, but they don't mess around with blood clotting, and they also don't disrupt GI mucosa. So all of that seems super good. The problem is there were some side effects. So here, I guess I did this. I didn't realize I did this. So here are some of these cellular mediators. I forgot that I did this in any more detail. Leukotrienes, we saw them on that little cascade. They're made by white blood cells. They cause chemotaxis, which means it causes blood cells to come to the area. They cause granulocytes to spit out their whatever they've got inside, histamine being an example, bronchoconstriction, vasoconstriction, increased vascular permeability. This is an inflammatory response. Prostacyclin is made in the endothelial tissues of our blood vessels, causes vasodilation, inhibits blood clotting. The PGE2 dilates bronchioles, causes redness, swelling, pain, and fever. PGF2 constricts bronchioles, vasodilation, uterine contraction. These things get released a lot when your skin is sunburned. PGA2, these guys reduce gastric acid secretion. Thromboxanes are made in damaged platelets. They cause platelets to stick together and also cause vasoconstriction. So these are all sorts of cellular mediators, which, again, for our class, you are not responsible for knowing. Do not commit that to memory. Just an idea, just to give you a kind of a little bit of an understanding of where these agents really come in. All right, so just to summarize for a second. So we've got salicylates, and you've got the anilines. So you've got essentially acetaminophen and you've got the salicylates. Pain, both of them, check. Antipyretic, both, check. The salicylates are anti-inflammatory and they also are antiplatelet aggregators, but they cause damage to the GI mucosa. And they cause syncytialism potentially, and maybe a little bit of kidney damage, but not super likely. The anilines are good for pain, lowering fever. They are not anti-inflammatory. So when someone's got an arthritic joint, they have pain, but this, there's a lot of people with these kinds of things going on. So the anilines aren't all that effective. So that's where the non-steroidal anti-inflammatories come in, right? Steroids are anti-inflammatory as well, of course, as we know, but steroids have a whole lot more side effects, which we're going to learn about in Unit 10. So steroids would be able to be effective for inflammation, but they have all these other side effects, which are, from all the way down from the suppression of the adrenal gland and the suppression of the ability to respond to stress, and all sorts of other things that are not great if you're taking them chronically. So that's where these non-steroidal anti-inflammatories come in. They're anti-inflammatory. They don't mess up the gut. They're not anticoagulant, but they do cause some issues. And the big thing with some of the, so the non-steroidal anti-inflammatories are looking okay, but then they had the COX-2 inhibitors, which seem to be like the answer to the issue for arthritic joints, pain and arthritis. But what we saw with the COX-2 inhibitors is what appeared to be more liver damage and potentially kidney damage, which is also common with the non-steroidal anti-inflammatory drugs. But then they started to see significant increases in heart attacks and strokes. And that was the big deal with the COX-2 inhibitors. And because of that, they ended up taking most of them off of the market after they'd come to market. So this was like, when we learn about the drug development, research and development, clinical testing, human trials. Then we get into phase 4, right? That sort of gray area where people are supposed to be kind of monitoring the drugs when more and more people are taking them. And that's where these increases in heart attacks and strokes started to be seen. And it started to become big enough of a deal that they really started to look into this, and they ended up pulling most of these drugs, with the exception of a couple of them, from the market. Not because they weren't effective, but because they had this adverse effect, potentially, untoward effect, which is increasing risk of statistically significant increases in heart attacks and strokes. So it's tricky, right? Like everything, there's not one answer, right? Pain is a very common deal. And of course, like the two, we've already talked about the narcotic narcotics for pain, but that's for moderate to severe pain ideally only, because of all the dependence and all of that stuff, abuse and dependence, right? Which of course in this day and age, as we all know, is reaching epidemic proportions, right? This opioid abuse that we have going on, right? So then we have to come up with something else. And so that's where these non-narcotic analgesic agents come in. And the big ones are the salicylates, the anilines, and the non-steroidal anti-inflammatory. And then under that umbrella of non-steroidal anti-inflammatories, we've got the COX-2 drugs, which, like I said, are mostly pulled now, with the exception of like 1 or 2 are still on the market. So it's muddy, as everything, it's complicated, but what you want to do is kind of focus on how they're similar and how they're different, and what makes each of these classes unique in terms of efficacy, therapeutic uses, side effects, and toxic effects. And I hope that's helpful.